Good morning, everyone. Thanks for joining us this morning for our last Collaborative Research Center for American Indian Health Pilot Grants Program seminar of this series. And I'm very excited to introduce Tai Mendenhall, who was one of our grantees. And unfortunately, Kathy Denman-Wilkie was unable to join him for this time, but hopefully you caught their presentation at the last summit. But Dr. Tai Mendenhall is a behavioral medicine specialist and associate professor at the University of Minnesota, U of M, in the Department of Family Social Science, which is my undergrad department, so I love that. Adjunct professor in the Department of Family Medicine and Community Health and associate director at the U of M's Citizen Professional Center. He is an expert in the conduct of interdisciplinary collaborative medicine and community-based participatory research focused on chronic health conditions and behaviors. Dr. Mendenhall's and colleagues' work through U of M's Citizen Professional Center encompasses more than a dozen community-based projects that involved active partnerships between professionals and community members. Tai maintains a strong track record and history of work in partnership with the American Indian community particularly. He is co-founder of Family Education Diabetes Series program, which developed through CVPR methods at U of M, and the Interfaith Action of Greater St. Paul's Department of Indian Work, and several local American Indian community members, elders, and leaders. Dr. Mendenhall is also a co-founder of the East Metro American Indian Diabetes Initiative that we're going to hear more about today, which is composed of 5 core organizational and community leaders who represent established and innovative organizations in St. Paul, who are highly invested in seeking knowledge and promoting the health and urban dwelling of American Indian people. Please join me in welcoming Dr. Tai Mendenhall.
Okay, so I need to click in the middle. Let's see. And then click.
Okay, now you should be.
All right. Hi. I didn't know I was the last one. I better make it good. End it on a good note. I appreciate you guys inviting me out here, and as was outlined in the introduction, I am one of many, and I just want to take a minute here and honor that. Kathy Denman-Wilkie, who is my official co-PI with this work, she regrets that she can't be here, but not really, because her son's getting married and she's really excited about that. So they've been like dating for 8 or 9 years, and she's kind of in the it's about time mode. So she's excited to be somewhere else, but absolutely helped me put this together, went through PowerPoints with me, and this is kind of a co-presentation of one, if that makes sense. But we also have our American Indian Family Center, St. Paul Public Schools Indian Education Ang Dayang Center, which is officially a homeless shelter for American Indian youth. They do a lot of other things too. That's how they started, but I'll talk a little bit more about them here as we go forward. Interfaith Action of Greater St. Paul used to be called the St. Paul Area Council of Churches. I won't go into that, but that administrative change was huge and good in a lot of regards in terms of their scope and the work that they're up to. And then the University of Minnesota, which I think is hiding behind the people you can see. Oh, that's kind of funny. Sorry. That's all right. That's okay. But as an introduction, you know, I want to set the stage or the context for the work that we've been up to, so it doesn't just come out of left field as this great, you know, hey, here's this smooth running machine, and they never are. You know, they look that way on the refereed journal articles that you read, but there's a lot of messiness that goes on behind the scenes. And I want to share a little bit about that messiness, because I really do think that the journey is more important than the destination, if that makes sense. And I don't mean to get all like therapy philosophical on you, but I think that with the stories of that messiness come the collaboration, the trust, the co-ownership of a lot of these types of efforts. And I think that it's important to honor that as part of the presentation in terms of where we are now, which is officially about this grant and about the data and about the next steps and directions that we have. So in terms of native health, and I don't think that I have to go into a lot of this with this group, but we know that with our American Indian communities, in a broad sense that there's a fair amount of disparities across biopsychosocial phenomenon. And a couple of my colleagues would also argue potentially about the spiritual arenas as well. But when we look at Minnesota, which is where a lot of our work, or most of our work, is positioned, we certainly have diversity in our American Indian communities, as you can see here. But then as it relates to the disparities across poverty, which of course overlaps with employment, with education with employment, with poverty, of course, and then all of those things, because they're all connected. You know, it's like a mobile that you hang on your deck. You know, you hit one part and every part moves. I mean, all these parts are connected with each other. As it relates to health disparities across a variety of different content areas in our Native youth, in our adults, our elderly. According to most of the epi studies that you can look at, you can see that American Indians are especially hard hit. When we look at diabetes per se, which is where our initiative is officially positioned, but it's actually a lot bigger than that now, and I'm going to get to that here towards the end. There is no group that's harder hit by diabetes. And, you know, if you average, no, it wouldn't be 1 in 10. That would be 0 in 10. If you average 0 in 10, I mean, the average is 5, right? So you go onto Google and you look at diabetes prevalence in the United States, and it's depending on which source you look at, about 6 or 7%. If there was anything else in this country that was 6 or 7%, I mean, it'd be all over the news every day. People would be like raiding the grocery stores for their bread and milk like they do in the South anytime it snows. You know, it'd be like, but arguably this is an epidemic. It's such an everyday epidemic, people have stopped caring in some regards. And when you look at that average of 6 or 7% of diabetes prevalence, it tells you nothing about different groups. You know, we do this at the U in our intimate relationships class too. 50% divorce rate means nothing. Start looking at people that are under 20 years old versus people that are over 40, people that have no money, people that do have money. I mean, throw it all together and you get a 50% divorce rate. It tells you nothing. Throw it all together, you get a 6 or 7% diabetes prevalence rate. It tells you nothing. In the American Indian community, I mean, depending on where you are, I mean, we have 30, 40, even 50% prevalence. I mean, that is more telling than the 6 or 7%. And when we look at different types of interventions then, to help, okay, so it's a big deal. Let's look in the literature. That's what all academics do, right? Got to review the literature. Can't walk down the hall unless you can cite somebody that says it's a good idea. Right? I mean, we taught you that. The professors taught you that. Most of the diabetes interventions that are out there don't include Native people. Okay, and then most of the diabetes interventions that are out there that include Native people are situated on reservation contexts. Most Native people don't live on reservation contexts. They live in urban contexts, and or they live on urban contexts a fair amount of the time, where access to Indian health services or a variety of other types of healthcare services are not as easy as they would be in comparison to other contexts as it relates to a variety of things, money being one, health insurance, certainly being connected to that, but then also just trust for Western medicine, you know, and what that looks like or what that feels like. So when we review the literature, there isn't really a whole lot to go on, or there hasn't historically been a whole lot to go on. And I think that that's getting better, but the ability to do that kind of research, say, okay, well, we reviewed the literature enough to figure out that we should probably focus on some urban contexts because we haven't done much there yet. And when we look at all those prevalence rates, the highest prevalence are happening in urban contexts. So let's situate it where we are going to get the most bang for our buck, the most impact for our efforts. Okay, and then we wonder, we being the white middle-class male researcher with a PhD from the University of Minnesota that wants to do good in the world, why nobody wants to talk to me, right? And it's not necessarily personal, but there's long-standing historical trauma, and I know I don't need to, go into all that with you guys here as well, but for good reason, again, that Native folks aren't just going to sign up and jump on board with the latest top-down, professionally driven research idea, du jour. I mean, it's just not going to work that way. And as we have looked at different what we call pressure points in medicine, I think that the stage then has been set for what we're going to be up to here and talk about today. In citizen healthcare and community-based participatory research, and it's called 1,000 different things. This is another review of the literature type of thing. I mean, it wasn't until NIH actually came up with the super long-winded term, community-based participatory research, and they did that to make a lot of other fields happy because it was action research here, and it was community research there, and it was community action research there. There were longer ones, community-based participatory action research over here, you know, and you're wondering why public health and social work and family therapy and medicine and different types of medicine, family medicine, peds, you know, and then nobody's citing each other because they all call it by a different name. So now we call it CBPR, but the term pressure point as a in common topic that we're concerned about, okay, is often one of the very first ways that these types of initiatives get started. And as we started to do that in the urban areas of Minneapolis-St. Paul, diabetes was universally identified as a pressure point. It didn't matter who you talked to. As long as you were connected to medicine somehow, this kept coming up. It was coming up from our patients because they were scared, because they couldn't afford the foods that the doctors were telling them, and then the doctors were getting mad at them for being non-compliant. They didn't feel safe going out and exercising in the neighborhoods, and then the doctors were getting mad at them because they were non-compliant. They couldn't afford the gyms that the doctors were encouraging them to go to. Doctors were mad because nobody was getting better. Administration was mad, frustrated because the 80-20 rule, that 20% of our patients cost 80% of our money, and that people that are coming to the emergency room, people that are having, it didn't need to be an emergency type of diabetic emergencies, and then the administration is having to figure out how to cover and to pay for that, especially when people are uninsured. So they were looking at it from different angles, but diabetes was recognized as something that we needed to do better. And as NIH and as a lot of other fields are starting to put these things together to say, you know what, when we're reviewing the literature, these top-down approaches don't work, right? We need to tap the untapped wisdom in healthcare, which is the knowledge and the wisdom, the energy of our patients. They might not have lots of letters at the end of their name, but they know more than me, right? Because I don't have diabetes. I don't live in poverty. I don't struggle with a neighborhood that I feel unsafe exercising in. Shouldn't we have them be part of the planning, part of the interventions, part of the design, even part of the implementations of what we do? And in some ways it's like, oh my gosh, of course. And in other ways it was completely like blow you away novel, for a lot of the folks that we were connected with. Partners in Diabetes was the very first one. This was health partners with Ramsey Family Physicians Clinic in a low-income neighborhood in St. Paul, connected to the Angels, and they were giving encouragement, love, and support, which was specific or is specifically connected to teenagers. And then from that came the feds. And that sets the stage up for what we're up to here today. 2 American Indian elders that were connected to the Partners in Diabetes project, which is a CBPR project, situated in a geographic area, not in an ethnic or a racial community, but in a geographic community, said, or to us as providers with the health partner system, can we work together in Native communities to do something here? And our initial thought was, yeah, we'll just replicate the Partners in Diabetes program, to which, they said it in their own words, but it said, you can't do that. Okay, you can't, and as I was learning about CBPR at this point, this was like a dozen years ago, you can't replicate CBPR. That's not the point. You need to connect with the unique stressors, resources of those communities that it's positioned in. And for the next 2 years, we really started to walk the walk on CBPR more than we ever had. And when I mean me, myself, a couple of physician colleagues, and a nurse, engaging in really, I think, this wisdom, again, that the biggest untapped resource in healthcare is not the providers, okay? And I learned from one of our elders, Nan Little Walker, that God gave me 2 ears and 1 mouth for a reason. She literally, I lost count, she literally kicked me under the table during many, many meetings to shut up. She's like, Tai, you can't talk. I know you're excited. I know you have a lot to offer. Okay, but there's a big mosaic of wisdom here, and professional wisdom is only part of that. Okay, and as then we gained this trust with each other, we came up with the FEDS. Family Education Diabetes Series. It's called the FEDS on purpose as some kind of way of, defiance against the historical trauma of the federal government across a variety of contexts. Nan Little Walker, Betty Green Crow, and Sheila White Eagle championed that name. They wanted it to be attention-getting. It's never called the Family Education Diabetes Series. It is when we present it, but it's always just called the FEDS. And people are like, really, the FEDS? Absolutely. So what this looks like is a form of education and support. The community comes together by design. It's not on the hospital or the university grounds. Those aren't perceived as safe. This is connected to the Department of Indian Work and the Interfaith Action of Greater St. Paul. That's perceived as safe. It's led and designed every single step, every single part of the iterative process through the CBPR lens of a collaborative co-ownership between professionals and community members. The group comes together, usually between 50 to 70 people every time. It's an every other week thing. We have health check-ins and weight, everybody, including the professionals. I mean, if it's going to be a flat hierarchy like CVPR, we need to do it too. Weight, BMI, random blood glucose, foot check, and people are excited for me when I lose weight, and they're giving me a hard time when I gain it. My data is in there too. So are all of our graduate students. Everybody is in this together. This is our project. We share foods that are consistent with Native American cultures, plural, that are also inexpensive and easy to cook, right? We talk about that. Instead of talking about portion sizes, we are eating the food while we're doing the portion sizes, right? CBPR, we identify different topics that we want to have the E be about in terms of education. By design, these are co-led between community members and professional members. So if it's about diabetes and foot care, we have people that have struggled with foot care and diabetes, maybe amputations, and then a physician that talks about amputations. Reading food labels, diabetes and stress. We always like to talk about the word stressed and the word desserts are the same word spelled backwards. People are like, writing that down. It's true, though, and then as we've collected data over the years, we find an average of 20 pounds of weight loss within 1 year, sustained out to 4 years and counting with our longitudinal data connected to this. Diabetes education, knowledge goes up. That goes up slowly, but it does go up. And as it relates to health behaviors, exercise, less junk food, less video games, more play, etc. That's a little messier to look at or to look at consistently, but we also see improvement there. It makes sense, go back to the mobile and everything's hitting. So that then, and the sign is out of date. Again, they just changed their name, Interfaith Action of Greater St. Paul. But these are different examples of folks that are going through the health checks. And you see, it's not a provider with a whole bunch of letters that they're into their name doing all the work. I mean, our community members are weighing each other. They're calculating each other's BMI. We set up a laptop there. We, as the providers, again, are going through as well. We have people that are doing the random blood glucose. This is an example of a co-presentation. That's Betty Greencrow. She just turned around at the wrong moment. But provider and community members doing talks together. Instead of talking about exercise at the gym, we are doing a variety of different types of exercises there on site. And then as that has evolved, and this is where this grant comes in specifically, although this grant is connected again to all of this, we are, because the Family Education Diabetes Series has youth in it, right? It has elders in it. It has men. It has women. And there's a variety of different organizations in Minneapolis, St. Paul that are like-minded that have historically had to compete with each other for grants instead of work together, that have had to compete with each other for time and space and activities and different things like that instead of working together, okay? And long story short, we got together and said, why don't we do that different, right? Because if the children here are connected to the school and they're doing this and the whole family's coming to the feds and the men are over here, why don't we write grants together and coordinate our efforts through that CVPR model? I bet we'll do better work. I bet it'd be like 1 + 1 = 6. And it is. And that's what's been so exciting as we've moved forward here with this work, again, guided by CBPR, which is, and I should have said this earlier, which is a Western label, okay? And it was so funny. just to continue in the sidebar for a second, because as this wet behind the ears, brand new graduate student person, I was so excited about this novel, and I ride Harleys and jump off bridges and do all kinds of things, and it seemed kind of fun to do kind of a little, edgy type of research. I'm going to do CVPR. This is very consistent with my nonconformist personality in some ways, and I loved this idea, and I was driven by this biopsychosocial spiritual idea of how all these things connected, to which Nan and Betty, and they were in those pictures there, said, medicine wheel concepts have connected those dots for millennia. And I'm like, oh, so it's not a new idea? And they're like, it's a new idea to Western medicine. You guys specialize, don't you? You put mental health down the hall and put physical health over here, or you need a referral to go to see somebody else, don't you? And they're like, yeah, and they're like, So officially, at least in the work that we do behind the scenes, it's medicine wheel. On the papers we write, it's CBPR guided by the biopsychosocial spiritual approach. But then we have the intergenerational community connections again, which connect the youth to the adults to the genders. The men's group, and this is where this grant has just been an extraordinary way of advancing the work that we've been up to, is that one of the things that was coming out of the CBPR process with the feds is that the majority of our samples, at least the majority of our samples that consented to provide data, were women, right? I mean, look at a couple of our earlier papers. We had like 70, 80% leaning on women. And that doesn't mean that there were 70 or 80% of the people that were there that were women. It's just the men didn't feel as comfortable participating. They weren't as consistent of participators, so the data were a little bit messier as we were following them. NIH was advancing entire calls to action to write publication or to write grants on how to engage minority men in health research. They're just falling through the cracks. It's not happening. Using the CVPR model with our men, we created the men's group. And again, men that are connected to the feds that are also then doing work out on their own to reclaim the role of the value, the sacred role of men in American Indian families. And in a lot of regards, they had lost it along the way. And it wasn't us coming up, again, with a top-down, professionally led idea. It was our men that are connected to the American Indian Family Center. Kerry Benson, he's one of our co-investigators that's officially on the grant, purposely led a lot of this to engage men in ways that were engaging. And they were telling us that, the feds is not so engaging to us. It's great for the women because it's a lot more talking circles and social interactions and education per se. And, they said it in a nice way, but they said the education to them was kind of boring in comparison to a lot of the other ways that they wanted to learn and to engage in healthy behaviors. And so and that was good to know. And then as we started to do that, again, with Kerry Benson at the lead and then a number of other guys that are just extraordinary in their own right, this is what the men's group is doing, okay? And as it relates to the dancing, the softball, they have softball and basketball all summer, softball and summer, basketball all winter, sugar bushing, the wild rice harvesting, a lot of different types of camping trips, canoe building. At the same time that we're talking about health, and the same time that we're eating healthy foods, they're just not sitting in a room with a couple of presenters up front, if that makes sense. And doing good or contributions to the community through a lot of that work is a part of that theme as well. It's not sugar bushing so they can bring it home and share it with their families. I mean, they're bringing it back and then sharing it with the community. The Elders Lodge, all of the repairs and the constructions and the thing, it's not just putting kids to work. It's something bigger and something more important than that. And the men's group is 200 men and counting at this point, which is amazing. Consistent participation across all of our groups, and of every single part of this larger project, the feds, the work that we're doing with the youth, which is two different groups, and then the men's group. The men's group is consistently the largest and the most consistent of all of them. And this is on the heels of NIH saying, where are our minority men, which has been really great because we as professionals have gotten out of the way more than we've led as it relates to a lot of the engagement and the work that has been effective. And certainly with the outcomes that we're seeing with them, it's working, and it's exciting in that way. Now with the youth, because again, family education series is kind of in the middle from which these have branched, a lot of the youth in the Feds program kind of felt like it was like, I don't know if you remember as a kid, you got sent off to the kids' table while the adults did the adult talk, which was super boring, right? And you were just hoping that there was another kid there because, you know, you would just like die of boredom if you were the only kid there. And a lot of the experience of the kids in the Feds was less engaging for them because it was really more of an adult type, you know, they don't care about reading labels or about where to, you know, go buy the best types of food or whatever. So it was less engaging for them. And so our youth, teenagers, and this is also connected to the wisdom of that other teenage group, the angels, in Ever Given Encouragement, Love, and Support. I have found consistently, and this is with our Citizen Professional Center and a variety of CBPR projects, is that CBPR with youth is 10 times faster and better than CBPR with adults. Adults have been socialized to be passive recipients of care. They have to relearn a way of working alongside the professionals that are relearning how to not take over all the time. Teenagers haven't been socialized to be passive yet. They're excited to, you know, they're so glad you asked, and they really, the pace and the energy of our youth with CVPR is just, I think it's the most fun part of the entire project because it is such a moving target. We never know what the heck they're going to do next. And it's one of the reasons why I'm on first name basis with half a dozen people over at our IRB at the University of Minnesota, because I'm always changing protocol. I'm back. Well, what are you guys doing now? Okay, well, okay, I'll see you soon, you know, kind of thing. But again, they co-own it, right? So we started with the DETs, or some people call it the DEETs. Do you guys know what it's called? It's Diabetes Education in Tribal Schools. You know, back in Minnesota, it's about a 50-50 split, and people get in arguments about if it's a longie or a shorty. Diabetes Education in Tribal Schools. It's an amazing project that has been standardized, and it's used and adapted. So standardized to the extent that you can then, you know, tweak it, you know, to the schools, to the environment that you're connected with. But connecting science, what we know about diabetes, to native cultures, again, plural, and ways that we can integrate that, but also with a strong push of getting native youth involved and interested in science and having career paths that lead to that. They've taken the DEETs, which is called the DEETs, and have personalized that across elementary and middle school grades in some really cool and innovative ways. Information campaigns that have started with diabetes and then spread out and focus in terms of smoking and healthy lifestyles and bullying and depression. Kids are functioning now in the context of what we call health messengers. They're doing YouTube videos that are connected to all those different topics. They're taking leadership in health fairs at schools, local powwows. We have a 5K that we do every year now. The first time we did it, we had 30 people, and we just did it again about a month ago, and we had more than 500, which is so cool. And again, native games instead of going to the gym or, you know, go for a jog around your neighborhood. And as we've continued to engage our groups around data, which I'll do here on our final stretch, the kids have taken a lot of leadership with that as well, not only in terms of themselves and their peers, but in terms of their parents, which anytime you do obviously work with youth, you have to, not like it's a bad thing. I mean, parents are part of that, you know, as well, and the kids have been real leaders in this. This is our men in their softball t-shirts, and they're okay. I mean, they win about half of the games, but that's not the point, right? They love it. They absolutely love it. Everybody shows up early. Everybody leaves late. And we're doing data collection as it connects to this grants on the softball field. I mean, you know, we're all over the map. You know, people are filling out stuff on the hoods of their cars. You know, they're running around because they don't. Again, that's where it makes sense. That's where these projects are happening. These are examples of the kids. And then as we connect all of those dots, the Family Education Diabetes Series, the work with the youth, I'm doing this by young, middle, older age, and then the work with the men, especially on the men's group, because again, most of the women are already connected to the feds. The questions then, okay, well, how does this officially, because the face validity is there, right? I mean, I don't think I need to convince anybody that, these things are cool ideas, that it makes sense to do this type of work this way. But especially in the arena of funding, and especially in the arena of publication or of dissemination of this work, others trying to tap or to go forward with their own wisdom on doing this type of initiative in their own communities, understanding that you can't replicate the program, but you can replicate the process, with CVPR, is where are your data? And as it relates to the group that certainly overlaps with feds, I shared some of those data, and that the evaluation components for the feds are covered by the Minnesota Department of Health. They've been funding that project for about, I think we're on year 6 now. But the men's group and the kids are the offshoots, the newer parts of the feds, and that's where this grant came in and has very purposely focused on the evaluation here. And diabetes specific, that was how the grant was framed. Our people's physical health, are we noticing changes, and what are those changes? Diabetes knowledge, as it relates to the diabetes knowledge test, which is like the most common, diabetes knowledge test or disease-specific test that's out there. And what about those health behaviors? And this is where, and bless you both on my reports to you, because it's so funny with CBPR. There's this constant tension on the deliverables, the timeline, the structure that you write out in your grant, and then the real life of the project. Okay. Now you can hang on to that structure and timeline really well in a laboratory maybe experiment, but with the messiness of CBPR, and we know that, and we write some of that into these proposals, but we were all in synchrony going to be starting the evaluations at the same time across the Young by Young Center, the St. Paul Public Schools, the men. All 3 of them had start dates that were about a month different from each other, and one of them hadn't even started yet, and the first report to you guys was already due. And I'm like, how do I do this report? Will you guys still like me? And then as it related with the and that was again normalized with the process, and obviously Sanford was sensitive to and familiar with the messiness of that process, and they've been amazing in that regard. But then as the youth started up, and we've experienced this as well. Now we have 2 IRBs. We have the University of Minnesota IRB, and we have the St. Paul Public Schools IRB, or they call it the Ethics Committee. It's similar. Different cultures, and that took a while. But then also, and again, appropriately so, understandably so, a lot of the parents that now we have consent forms and we have assent forms, right? The parents that aren't there, that aren't involved in this work, are learning about this University of Minnesota thing, and they want to research my kid, right? And if that's all they have to go on, then I wouldn't sign it either. I mean, and obviously the kids are really engaged in this. The work was happening. The evaluation wasn't, because the parents didn't feel comfortable having the data collected in that kind of formal way. Now, data are being collected all the time, to be sure, internal data. We always do that. I mean, that's part of the CBPR process. But in an official capacity, we were having, out of 30 kids, we'd have like 4, that were officially consenting. So a lot of our reports for the first couple times were all coming out of the homeless youth shelter, because the shelter officially was designated as the guardian that could consent the kids. So we didn't have any problems there, but as it related to the public schools, there was a lot of work. And then going back to the CBPR process, instead of us as professionals, let's figure it out, going back to the community and saying, what would be the most appropriate steps or responses to this? To which we held a number of talking circles with youth and parents, talking more about the project, about the ways that data were going to be collected, the ways that data were going to be disseminated. One of the things that came out of that is that we pulled the physical data all together from the schools, because the parents didn't want that. They didn't want any, because they felt that was too intrusive. They felt that it would potentially be embarrassing, especially to the girls. And so we did. We pulled it out. And then we emphasized again the behaviors and the knowledge. That felt more comfortable. Our consent forms started to go up. And then almost towards the end of the grant, we started to get more robust, findings as that. But then because it had started so late, this is why our 1-year grant is a 2-year grant. But the momentum and the buy-in and the involvement of the parents of those kids, those parents are now starting to come to the feds, which is part of the whole reason we did it, because we wanted the kids to have their parents at the feds and have their dads over at the men's group, and then have everybody go to the powwow and have everybody go to the health fair, and then they're talking to more youth that are going to start now this work that is happening back over here with the school. Those parents are going to get engaged, and they're going to come to the feds too. Does that make sense? Again, it's that the whole being more than the sum of the parts. The other thing, and again, this is connected to the messiness of CBPR, this was about men's group, because when we have men that are connected to the men's group that are doing men's group things, broadly defined, we also have a whole bunch of their family members that are coming to all of the games that are also learning. They might not be officially a member of the men's group, but they're there, they're participating. It's a collectivist culture. It's a CBPR project. Can't they offer data too? Shouldn't they be able to? How do they consent? Are they really a research participant? And then we have a diminished consent situation because we have incentives with gift cards to fill out the surveys with people that oftentimes are living in low-income situations, and, oh, you get a gift card, but you don't. They're going to fill out the survey on the same project that you've been participating in. Does that make sense? And so, going back to the CVPR processes, this then overlapped with MDH and the FEDS project, that we do collect data from everybody, but for the purposes of the grant, it's only the men. That's what we're reporting, but there's a whole lot of other data that are being collected and other gift cards that are going out that are funded through other grants that are specific to the feds, but they come to the feds too. We're just collecting data offsite. Does that make sense? And then it works, okay? But the, and the CITI training that you have to do in order to formally consent people, we have about a dozen folks that are in the community that have gone through all that because we need that much help. When you're on a ball field and everybody's running around, I need a whole bunch of native folks that have gone through the CITI training that are officially in that capacity with the grant that can consent people and keep everything straight. It's messy, but that's the point. I like messy, and I think that the richness of that process, and also for the co-ownership with the group, if it was always perfect, it wouldn't be as cohesive. I mean, going through and figuring out and solving these problems together is in part a necessary process of CBPR. In a lot of our projects, I don't think that they really are stable until they've been in crisis. And that isn't like a reframe. I mean, I really do mean that. And as it connects then to the stability of the projects, I think that that's probably the most important point, and I'll end on that here in just a second. And so, yes, we are seeing improvements in health, especially with our men. The kids, in a lot of regards, aren't as unhealthy to begin with, so our findings have been a little bit less. Depending on which cycle, we've seen significant, and we've seen trends, okay? Everybody in an average, although, again, remember our averages, 0 and 10 averaging to 5, is on the low end of the obesity range on BMI, and most of them start out on the high. So that's good. Knowledge, and I could talk all morning about this one. People's weight is going down, people's healthy activities are going up, so does it really matter if they know the difference between rice, potatoes, and squash on calorie count? A lot of the community says no. It's kind of like in therapy in the mental health world. I mean, you can spend 6 months figuring out why you're depressed, to which a contemporary-oriented theorist would say, well, do you feel better yet, or have you just spending 6 months developing insight? I mean, insight isn't really where the change happens, right? The change happens in terms of the behavior, and others would say, well, insight's necessary for change. Others would say, no, it's not. Go exercise, right? And so the jury is out in some of this regard, but then alongside our talking circles and our qualitative data, because a lot of these projects are pretty blunt instruments. Well, geez, you educate about this, you educate about that, you have the softball and you do this. What's working? Where is your outcome coming from, right? Because you're doing 100 things. If anybody wanted to replicate even the process, they wouldn't even know where to start. What's coming out of the qualitative components of this, which is, again, we're always coordinating the MDH with Samford, because the qualitative work is coming out of the MDH, is that it's more about the social support than anything else. I mean, we could be having a talk at the feds about basket weaving. The point is everybody's there. They're in it together. They're supporting each other, and they're accountable to each other. They're celebrating, again, the weight loss. I lost 2 pounds last time, and everybody's excited. I mean, HIPAA would lose its mind in that context, but CBPR is, different than that, okay? And so the social support that's driving the behaviors which influence the physical outcomes, I think, I don't think the knowledge is very compelling. I mean, our data have never once been a consistent change. I mean, people are relatively knowledgeable, but we're not seeing a whole lot of change in that, okay? The health behaviors, huge, okay? And people are talking about that they're exercising more, that they're, again, getting out, being active, that they're reading the food labels, that they're figuring out where and how to go to different farmers markets in their respective food deserts. They're getting really upset that the special at McDonald's for a hamburger, fries, and a Coke is $3 and a salad is $7. And so they're doing different things there, and that's motivating to them, right? And I think that, again, a lot of the findings are good. The biopsychosocial spiritual and the broader frame of diabetes that's coming out of both of these is where they get even better. And this has been one of the most fun things to talk about in our reports to Samford, to say, hey, we have more findings that we didn't even think were going to happen, right? We didn't write this into the grant, but they're so clearly integrated into the work that we're up to that to separate them out and not tell Samford because we're just going to report our physical data would be like showing half of a picture, like with some blacked out fuzziness that you see, like when you, I don't know, see something on the news that they don't want you to see, okay? And that is that depression, social isolation, suicidality, and sobriety are some of the biggest findings that are coming out, especially with our men. And when we were here last time, there were a couple that was starting to happen, and even since then, there's been, I might not be right, it might be 5, but I'm thinking like at least a half a dozen other guys that have shared that they were suicidal with a plan until they got connected with this group. And that in that regard, yeah, maybe they're more physically active, but it saved their life in a more, I think, important and impactful way, okay? And, depression, anxiety, drug use, alcohol, opioid, whatever you want to fill in the blank with, all of the disparities that have been happening in the American Indian community that I started with are happening there as well. And the biopsychosocial, spiritual, going into the psycho and the social parts, I think are some of the biggest findings of all of this, even though it's a diabetes study. Okay. With our youth, in many regards, the same thing, although the struggles with suicidality and the struggles with drug addiction and alcohol abuse are less. They're certainly still there. But often as it relates to depression, bullying, and social isolation, right? And we know that when you're depressed, you can't sleep, right? And we know that when you're depressed and you have insomnia, you usually gain weight. You don't feel like going out and being active. Again, everything's connected. And these health messengers videos, right? And I have links to different YouTube videos if you guys are interested, where these kids have just been amazing. Not because they're spreading the word of good health, but because they have gone through their own journeys and want to share that with somebody else. It's like step 12 on AA. that the most qualified person to connect with somebody that's struggling with depression and suicidality is probably somebody that's been depressed and been suicidal, right? Because they know it in a different way than the textbooks. Coming full circle taps the untapped wisdom that we're tapping in CBPR. Okay. Next steps. We are meeting across our different organizations in our own different types of talking circles about different ways to advance and to coordinate a lot of the groups, the Fitbits, the YouTube videos, the digital storytelling, which have been kind of natural offshoots, are going to be more purposeful and consistent across all of this. We're doing qualitative data as we speak now in terms of the different perceptions of health, purposely with medicine wheel frames, biopsychosocial, spiritual frames that aren't as connected to diabetes anymore. It's connected to walking in balance and healthy life, okay, and healthy lifestyle. At the same time, of course, that we are collecting and tracking a variety of different data along the way, but that data are going to become a lot more diverse than just the physical data as we're doing. So right now we're looking at PHQ-2s, PHQ-9s, the Beck depression, Beck anxiety scales, for example, figuring out what fits, what doesn't as it relates to literacy and cultural appropriateness. Stay tuned. I'd say in the next 6 months we're going to be integrating a lot of that into the ongoing work as well. So I was supposed to end at 1:45. It's 12:02. Not so bad. Thank you. Questions, ideas, or discussion?